Hello, I am John Russell. I'm coming to you from Johns Hopkins. This is the surgical lounge at Weinberg in the Cancer Center at Johns Hopkins. Uh, it's spacious, as you can tell. Happy to be with you, at least virtually, and hope that your conference is great. It seems like it is an absolutely fantastic conference with lots of really wonderful speakers. Very honored and excited to be able to speak with you today. And I was asked to talk about whether or not transoral surgery is changing endocrine surgery overall. My disclosures, first of all, I'm leaving Johns Hopkins Hospital. I'll be starting my own Center for Endocrine Excellence here in the Washington, D.C. area. Also, I need to disclose that part of this work is covered by an NIH grant. And finally, that I am a consultant for Baxter Scientific, although that is not terribly relevant with the work that I'm presenting today. Let's talk about background. I think for background, as we go into whether or not transoral surgery is changing thyroid surgery overall, I want to kind of go through a little bit of where we've been in the past and where we're going in the future and how transoral surgery plays into that. So I think the first thing to talk about is transoral surgery. Of all the different remote access surgeries that have come onto the scene before, as this graph shows, it's a series by Dr. Benucci previously at Cornell. Now she's at MD Anderson. You can see she goes through the different surgical approaches, the breast approach, the transaxillary approach, retroauricular. And you can see that over the first 5 years that each of those types of thyroid procedure was around, there was relatively little investment, very few patient cases that were presented or published over the first 5 years. And you can see that that's very different with transoral surgery. Starting in 2016, the volume of cases that were published just really exploded relative to the other ones and has continued to increase since that time. And so I think it's important to point out that transoral surgery is, of all the remote access approaches, by far the most popular. So let's talk about, again, the background of thyroid surgery in general, the growth of transoral surgery, why it's important, and how it's going to change endocrine surgery overall. Now, historically, I work at Johns Hopkins currently. Dr. Halstead was really one of the founders of thyroid surgery in North America. After going abroad and learning the international technique that won Coker a Nobel Prize in the early 1900s. And the same thing happened at the Mayo Hospital System and at the Cleveland Clinic Hospital System. These American surgeons went abroad and learned new techniques and brought them back to North America and were able to establish large hospital systems because they did something better than the other hospitals around. They were able to do safer thyroid surgery. And so it really was foundational towards building new surgical advancements, towards building large hospital systems that still affect American healthcare today, more than 100 years later. And so we know that thyroid surgery has played a very large role in changing and affecting the overall healthcare landscape. We also know that thyroid nodules are everywhere in North America. Up to 80% of Americans will have a thyroid nodule. Thyroid cancer is indolent, and thyroid surgery is very safe. And so it creates this situation where even though and this graph has changed a little bit more recently as the incidence of thyroid cancer in North America at least has started to plateau a little bit as we've stopped looking for it so much. But we know that the mortality and morbidity of thyroid cancer is fairly stable, but the incidence is quite high relative to the number of patients that are going to die from thyroid cancer. And so as you look at this graph, it creates this opportunity for us to really innovate with some of these patients to drive morbidity from the surgery down quite a bit. And so what does that mean when we're talking about morbidity? We've talked a lot in the past about things like nerve monitoring, and Dr. Plitt talked to you a little bit about how do we identify patients who need surgery and who doesn't need surgery using some genetic markers. We're doing lots of different things to help with morbidity. And one of the things that we know affects morbidity is whether or not patients have a scar. And why do I say that we know that it affects morbidity? I would argue that just the simple fact that there are so many different remote access approaches is one way that we know that it affects morbidity. You wouldn't have tried the transaxillary, you wouldn't have tried the aerial or the retroauricular. You wouldn't have tried all of these if there wasn't some desire to avoid having a scar right in the middle of a neck. Usually it's the neck of a young woman. And so it's been hard to quantify that. Usually the South Koreans are leading us in a lot of these advancements when it comes to thyroid and cosmesis. And in this case, they were the first to publish series trying to figure out how much having a scar actually impacts quality of life. And what they found in this early series by Dr. Choi and colleagues was that having a scar on your neck affected your healthcare quality of life as much as having psoriasis, vitiligo, or severe atopic dermatitis. And so as we talk about trying to decrease morbidity, that should be something in our mind, is just the fact that having a scar does affect the quality of life of some patients, maybe not all patients, but some patients will be bothered by a scar. And so this is a series from Indiana, which is kind of right in the middle of America. It's farm country, and these patients are all about 5 years out from surgery. And what you can see is that after 5 years after surgery, about half of all patients think that their scar is excellent. And for me as a surgeon, I expect every single patient to think every single thing that I do is excellent. And if they don't think that it's excellent, then that's an opportunity for me to do a better job. Even more than my patients not thinking, or rather these surgeons' patients not thinking that they did an excellent job with the scar, about 20% of patients were self-conscious, and about 10% of patients were thinking about having a scar revision 5 years after surgery. And so again, that kind of shows that there's an opportunity for us as surgeons to do something better for our patients so that they can have a less morbid surgical procedure and a better quality of life afterwards. That jives with some other recent work that has found that the number one adverse event after surgery, the thing that people complain about the most, is the appearance of their scar, with almost 80% of patients saying that their scar didn't look right after thyroid surgery. So pretty high numbers. In Baltimore, we tried to quantify this a little bit more. We asked people to look at pictures of patients with a scar on their neck and pictures of patients without a scar on their neck, and then to tell us whether or not the scar bothered them, or rather the people looking at the scars, whether or not it bothered them. And as we asked 200 people to look at these pictures, what we found is that if you have a scar on your neck, or at least the pictures of people that had scars on their neck were perceived to have a lower quality of life, and they were perceived to be less attractive than the people who had or who did not have scars on their neck. And when we asked the people looking at the pictures to try to figure out how much that scar mattered to them, they said that they would pay more than $10,000 so that they didn't have a scar on their neck. So pretty significant. The next study that we did was we tried to look at people's eyes when they see somebody who has a scar on their neck, and we wanted to see if their gaze is distracted, because ideally when you're talking to somebody, they're kind of focusing in the middle of your face. They're kind of looking here in the central triangle, and you don't want them to be distracted and look down at your neck or something else. You want them to kind of stay focused on your eyes, and it lets them know that they're paying attention to you when you're talking to them. And so we tracked the pupils of people who were looking at pictures of patients who had had surgery. And then we were able to generate heat maps. And with these heat maps, what you can see is that the patient on the left has a thyroid scar that actually healed pretty well. But the fact that she has a thyroid scar means that other people are looking down at her neck and they're distracted by the scar on her neck. And so they're not just focusing in her central triangle, they're also looking down lower on her neck. The patient on the right is a patient who has a small mole. And even just having that mole, she's had 0 surgery, but even having that mole was enough to distract the gaze and make people look away from her face. And finally, the patient in the middle is a thyroid patient who had transoral surgery. And you can see that all of the gaze is focused in that central triangle, which is exactly where we want it to be. And so we hypothesized that she is less likely to be other people, when they talk to her, are less likely to be distracted when they talk to her. And so maybe that improves communication. And so that's kind of what our hypothesis is when it comes to whether or not having a scar actually matters. And so maybe we can start to make the argument that avoiding a scar can improve communication, and it might make patients think that your surgery is a little bit more excellent, and you might be able to avoid some of the morbidity that comes after thyroid surgery. But the next question is, can you do it safely? Because we know that normal thyroid surgery is very, very safe. And so this is our first series that we looked at, and what we found comparing almost 100 patients with normal surgery to 150 patients with remote access surgery was that the patients with remote access surgery, there were no patients who had a permanent nerve injury, and there were no patients who had a permanent hypoparathyroidism, and patients did really well. We were able to continue this series out, and what we were able to find was that over time, this procedure was just as safe as the normal open surgery when done by thoughtful and experienced surgeons. And so since 2017, I've done more than 600 transoral thyroid and parathyroid surgeries. I've had 0 permanent recurrent laryngeal nerve injuries, and I've had 1 patient who has permanent hypoparathyroidism. And so this has really become kind of a go-to surgery if patients are even a little bit concerned about cosmesis. The people always say, well, it's probably very expensive. And so we went through and we looked, and I think most surgery in North America is pretty expensive. But when you look at the equipment, it's fairly similar. It costs about $300 more to do a transoral surgery than it does to do an open surgery. And then the amount that the hospital bills, which includes anesthesia and time and things like that, it's pretty significantly more expensive when you do robotic surgery, but otherwise the difference is mostly just to do with time. And so the next question is, well, does it take you a really long time to do transoral thyroid surgery? And you can see that at the beginning, it does take quite a while, but there's a steep learning curve, and that learning curve keeps going down over time. You get faster and faster as you do these procedures. And you can predict which patients are going to be challenging, and it's mostly just how big the thyroid lobe is. And a little bit, it also matters how big the patient is, whether or not they have cancer, and then also whether or not they have Graves' disease. But we also were able to find that at least in North America, most patients are eligible for transoral thyroid surgery. And so it's not just a niche procedure. It's something that a lot of people can have. Finally, you want to know whether or not it's impacting or improving the quality of life of your patients. And so this is a series that we did where we looked at the health-related quality of life, and we sent patients lots of different surveys. We asked about quality of life in every single domain on the SF-36, which is a well-validated survey. And then we also asked about swallowing. We also asked about their voice. What we found was that in every single domain on the SF-36, quality of life was better if patients did not have a scar. And we found that even 3 years after surgery, patients were doing slightly better if they had scarless surgery. Finally, what was most significant was that patients were more than 3 times less self-conscious about their skin and neck if they didn't have a scar. And so you should remember that this is a very select group, because this is only patients who were eligible to have scarless surgery. And even if they told us that they didn't care about having a scar or not having a scar, people were less self-conscious, which means that some people are self-conscious even if they have a choice and they tell you that they're not going to be self-conscious. And so we were pretty gratified to find that this surgery seems to help people with their quality of life, and that people seem to do pretty well after this surgery, at least as well, if not better, than patients who have normal thyroid surgery. And so I think that all of this is good because it shows that maybe transoral surgery is valuable. But the question that I was asked to talk about was, is transoral surgery changing endocrine surgery overall? And I think the way that transoral surgery changes thyroid surgery overall, or endocrine surgery overall, is twofold. The first thing that it does is it makes patients a little bit safer, but it also allows us to innovate even more. And so I'm going to talk about 2 other innovations. And the first one is autofluorescence. And you can see this is open surgery autofluorescence, where you can see it makes the parathyroid gland really shine. And this is an NIH grant that we're working on developing a new parathyroid autofluorescence device. It really makes those parathyroid glands obvious to find, and therefore safer. And so as this is spurred along by transoral surgery and innovation, it just shows surgeons, hey, we have to be innovating. And for a long time, we had been doing surgery fairly constantly, a normal cervical incision, and things kind of stay the same. But once we start to use cameras, we get to be even safer, and we get to do even more. This is an endoscopic transoral surgery done by Dr. Wang in China. And you can see that he's developed an artificial intelligence overlay that helps to identify parathyroid glands intraoperatively. And you can see that green box telling the surgeon that that's where the parathyroid gland is. And as they proceed, you'll be able to see the parathyroid gland become devitalized, at which point this box will turn red. And so I think this is a fantastic example of how you can do surgery safer and safer by having additional artificial intelligence devices involved in your surgery, which are things that are even a little bit more challenging when you're doing open surgery and you have to rely on your naked eye. And so this is just an example of how, as you do transoral surgery, it's changing surgery because it demands and spurs innovation. But I think that there's another point that's even beyond that, and that's the point where surgery and medicine start to become indistinguishable, when everything starts to come together. How can we make surgery and be just so easy to recover from and so safe that it's almost medical, almost like taking a pill, almost just something that we do and that patients don't have to recover from. And I think we're getting closer and closer to that. And the way that I think that transoral surgery has changed thyroid surgery more than anything else is I think that it has spurred radiofrequency ablation adoption in North America. Because in North America, surgeons realized that there was a technique that other people were doing that did not cause a scar. And surgeons realized, wow, we have to mobilize because I don't know that technique. What else can I do? And surgeons began to look for other things like radiofrequency ablation of thyroid nodules. Unfortunately, we adopted that very early here at Johns Hopkins as well. And we started doing that. We did a combined study with Stanford and Tulane. And what we found is that radiofrequency ablation is very effective at reducing the size of thyroid nodules. And this is benign thyroid nodules, where most thyroid nodules will decrease more than 50% over the first year after treatment. And so we found and suggest that radiofrequency ablation can be applied with lots of different strategies for benign thyroid nodules, and that most patients will have a good outcome with very few complications. And so it should be something that you're considering offering your patients as you're considering treating them for their benign nodules. And again, I think that transoral surgery kind of played a big role in this being adopted quickly in North America. We're also using radiofrequency ablation for thyroid cancer. Here on the left, if you can see my mouse, you can see a picture of a small cancer in a young woman. On the right, this is her ultrasound a year after radiofrequency ablation, and you do not see any evidence of residual cancer in that area. And so pretty exciting, the things that we're able to do without doing surgery as we get better and better at doing radiofrequency ablation. And you can see the volume reduction rate, that as we treat these small cancers, they get even smaller and in some cases completely disappear. So we're pretty excited about that. So how is transoral endocrine surgery changing endocrine surgery overall? Well, it's driving innovation, and innovation drives safety, and it really makes us advance in ways that we have not advanced over the last 100 years. And it really has been part of what has spurred a lot of changes. So really an exciting time to be an endocrine surgeon when we have so many different things that are so many different opportunities to learn, to grow, to offer our patients a safer surgery, better outcomes, better techniques. Really excited for all of you to be at this conference and to learn about how different ways that you can advance your skills. Such a privilege and an honor to have been invited, and best of luck as you have your conference, and hopefully would love to talk to any of you going forward. Thank you so much.